morning. So it's my pleasure to be here and share with you how we can combine all these tools in our routine practice for mainly doing and scanning the patient. So this is all around what is multiparametric ultrasound imaging, and the concept is really very close from the MR concept. Basically, we're using our best B-mode anatomical imaging techniques to really assess the lesion and try detection, and also assessing the B-mode pattern of the lesion. And then we also try to get vascular information, and this is done with all the Doppler techniques available in the system, including the UltraFast Doppler or ultra-sensitive Doppler techniques like angioplasty. Then we have also the possibility to test in a non-invasive way the tissue elastography, and this can be done with a shear wave speed or shear wave elastography, but also we can use some pulse wave velocity. And basically, all these can be combined in a picture with a 3D and fusion imaging, which is very, very exciting and probably leading in the future to functional ultrasound imaging. And this is the kind of approach that can be done where you can combine all information at the same time using fusion imaging, where you have both the elasticity information, the shear wave elastography, and you have also the B mode and all information coming from the fusion imaging. But basically, we cannot use all these tools in all patients, as you are probably aware. So how can we do it right now? Basically, we always start with B mode, and then we had the conventional color flow and directional power Doppler imaging. Then we use in a routine practice the angioplasty and the shear wave elastography, because shear wave elastography only takes less than 1 to 2 minutes to just focus on the question. And then it really depends if we have no lesion suspected in a very, very broad way, and then we just stop. And then if we have any suspicion of a lesion, then we move to contrast enhanced ultrasound, depending on the indications. Of course, we know that fibrosis assessment can be done right now with a 2D shear wave elastography, and this is a real-time imaging technique. But also there are new tools that are becoming available and that are under development for steatosis assessment. You can use a very simple but pretty good efficient technique, is just measuring the hepatorenal brightness index. So that's the hepatorenal ratio. You can also try to assess the backscattering, because we know that when the fat is increasing in soft tissue, the backscattering is increasing at the same time. We can also calculate some kind of attenuation parameter, because we know that when fat is increasing in the tissue, attenuation is increasing also. And very recently in the Explorer also, you can play and optimize the speed of sound, because we know that when fat is increasing in soft tissue, the speed of sound will decrease. Basically, we for liver and mainly for tissue, quantitative assessment of the stiffness can be achieved with a shear wave elastography, and basically these techniques has been validated for fibrosis estimation, as it has been shown on the previous talk. So my purpose is really to show you clinical cases from the real life. Some of them will have very nice imaging, some of them have less good, but this is really what we can get. So this is first a patient, a lady coming with a metabolic syndrome and some kind of NASH. And this is the B-mode imaging. You see a slightly bright tissue, but quite uniform. And it's pretty nice, some deformation of the borders. So no real attenuation. You can compare the brightness of the liver compared to the brightness of the kidney. The normal hepatorenal index. So basically, we see no steatosis. And basically, next step is really to move to fibrosis assessment. And we do think that right now, shear wave elastography can be done in any specific liver examination. And that's exactly what we're doing, just assessing the elasticity of the liver. And then we see that this is strongly enhanced. So the liver is really stiff. You see a stiffness measurement around 20 kilopascal. So certainly a fibrotic or at least an increased stiffness in the liver. And then the next step is obviously to look for a blood flow disturbance, both at the level of the portal vein and looking for collaterals. And you see a slight reduction in the Doppler waveforms and velocity in the portal veins. So then we know that the spleen is a very nice organ and can be also assessed with a shear wave elastography. And the spleen is not enlarged, as you can see, but the stiffness is significantly increased. You see values up to 36 kilopascal. So clearly, we know that now we're facing a patient with cirrhosis and portal hypertension. Of course, the next step will be more defined analysis of the liver parenchyma. And then you see all of these small nodules, both and the disturbance of the blood flow with the angioplasty techniques and with contrast. You see all of these small nodules. Maybe we can reduce slightly the light inside the room. Just to let you evaluate all of these small nodules inside the distal and subcapsular areas, just showing that this is truly a patient with a cirrhotic disease. So this is exactly what we do in our routine practice. Another case, a patient coming with 3 focal lesions, and the discussion is, should we biopsy this lesion? There's a follow-up, of course, at the second examination. And then first step is obviously to assess the size and the pattern of these lesions. And you see that there's one that is pretty big. It's almost 11 centimeter in maximum diameter. And of course, then we look at the Doppler, and then we see that these lesions are vascular. The larger one has little information about the blood flow pattern. On the smaller ones, you see some kind of stellar pattern, maybe, maybe not. It's very difficult, but the deeper one has clearly a pattern with a stellar distribution of the blood flow. So maybe this one is FNH. The other ones, I'm not so sure. So let's move to stiffness evaluation, and then we see that all the lesions are really stiff compared to the liver, and then the normal liver has also normal stiffness values, and in this case we're slightly pressing on the transducer to get information on the elasticity of the focal liver lesion. So normal liver stiffness, stiff lesion, some kind of vascularity, and then we use the angioplasty technique, and you see how much we can improve the detection of the blood flow. And with this pattern, of course, it's much easier to assess and confirming that this lesion is FNH. So that's very interesting, and this is another one, and then you can compare with the normal blood flow imaging technique compared to the angioplasty, where we have a much higher resolution and much higher sensitivity. And I'm sorry that this is going very, very slowly, probably because of the network. So again, in this case, we can assess and put multiple Doppler windows to assess on this single acquisition the blood flow pattern, and we see that all of these are arteries, and this is just increasing our confidence in the presence of these multiple FNH. Next step is probably just doing the contrast enhanced examination, and look, we are using here the linear transducer. The dose is 0.3 ml, and this is just because we just want to see the internal vessel of the lesion, and then we're scanning with 1.2 ml the entire liver, confirming the very, very typical pattern of strongly enhancing lesions, very typical for FNH, and you also saw the central scar on this lesion. So that's the way we just manage the patient. In this third patient, coming with an incidental focal liver lesion, I have no information about this guy, just 64, and then with a conventional convex transducer, you see that there might be something in the subcapsular area, And I would like to encourage you to always move to a linear transducer. The low-frequency linear transducer has a wonderful imaging performance, both with B-mode and Doppler for the subcapsular areas. And then we see very much that this lesion is poorly looking, and I'm really anxious when I see these lesions with a poor delineation. And then with color, you see that the lesion has some kind of vascular pattern, and you see that this pattern is mainly peripheral arteries. And basically then we move to shear wave, and again we have a very stiff liver with values between 24 and 30 kilopascals, and that the lesion also is slightly stiffer. Then we use these highly sensitive technique like UltraFast Doppler. And with UltraFast Doppler, we can record and confirm that all of these lesions are just basically arteries. And then at the end, we will just inject contrast. And with contrast, you see that the lesion has some kind of washout very clearly, and is strongly enhancing during the arterial phase. It's very typical for a HCC. So basically, this guy just came for a regular ultrasound and is leaving the room with the diagnosis of cirrhosis and HCC. And this is not an unusual situation, and we know that just doing shear wave elastography on liver in a patient with no previous history of liver disease, we can detect up to 10% of patients with a significant fibrosis. So now I would like to move to multiparametric ultrasound prostate imaging, and we know that all the techniques that we have, and prostate is clearly a very difficult organ to assess because the diagnostic tests available like PSA or conventional transrectal ultrasound or even MRI and biopsy has a limited performance. And this is a recent study showing, coming from Lee in European urology, showing that we are missing up to 75% of the small Gleason 6 lesion, but even almost 50% of the Gleason 7, 4 plus 3, and even 30% of the Gleason 3 plus 4, and this is 4 plus 3, and these are the bigger ones. So we are missing a significant number of even significant prostate cancer with MRI, and this is a very important message. But now, with the Explorer, we have the capability to do prostate fusion in a more automatic registration way, and basically we can stick this device on the patient, and then the device will be recognized by the ultrasound system, and we will be able to do the fusion in a very automatic way and do the biopsy also in a very automatic way with fusion imaging. But shear wave also can be combined with these fusion techniques, and we know that shear wave elastography is really a clear tool that improves the detection of prostate cancer. And you see that when we do ratio between the lesion that we can see and the surrounding prostate, then you see in the peripheral zone, you see that these the malignant lesions are strongly stiffer compared to the benign lesions. And you see that the performance in both per sexton and per patient evaluation, you see that the sensitivity, specificity, and negative predictive values are pretty high. So let's see this patient with a PSA of 13, 60-year-old, no previous data, no previous ultrasound, and then we're scanning the patient, and then you might see here small hypoechogenic area, some increased vascularity, but look at the shear wave elastography. Really, it's an obvious, and it's a very large lesion. And at least there's a very large increased stiffness in the prostate. And this is coming from the base to the apex. So it's quite diffuse lesion. And now we can combine the shear wave information to the contrast-enhanced ultrasound. And you see how much the lesion is enhancing. So we are here in the case of a patient with a very aggressive lesion. And basically, this was confirmed with the MR study was done prior to the biopsy, confirming the size of the lesion, and biopsy confirmed that diffuse cancer was extending in the entire left lobe of the prostate, a Gleason 7 cancer, 4 plus 3. In this other man, you see the PSA was just subnormal, slightly abnormal, stable, no previous data. MRI was impossible due to the non-compatible pacemaker. The previous ultrasound study showed no specific area, no suspicious area. And even my own ultrasound didn't see anything wrong, both with the B mode and directional color power imaging. No specific target, no specific abnormality. But look, as soon as I push the shear wave button, oh my God, there's something here, and this is anterior. So of course, this can be easily missed by systematic biopsies or even targeted biopsies if you have no target. And you see that this area is strongly stiffened compared to the contralateral size, 68 kilopascal versus 28. And then basically, we just confirm that the lesion is strongly hypervascular. And look at how much hypervascular is the lesion. We did the targeted biopsy. All targeted biopsy showed Gleason 8 lesion adenocarcinoma. The systematic biopsy showed no cancer again, and the patient was referred for radical prostatectomy that confirmed that the only cancer site was Gleason 8 and at the base of the prostate, and it was quite anterior. So very interesting if you want to improve the detection of the lesions, and this is only and the last case is a patient with a PSA of 10, and was one suspicious area, but poorly suspicious, was classified PARADS 4. And then B mode also, in this case, showed the lesion. Again, one specific target. And then we can also do 3D acquisitions, and we could do 3D with a multiplanar reconstruction in both transverse and coronal plane with the Explorer. You see the Doppler reconstructions also, and you see the shear wave reconstructions, and you see that the lesion is really stiff. As you can see, it's quite obvious. And then with contrast, you see very strong enhancement in the entire left lobe, and biopsy confirmed Gleason 7 lesions. So really, I do think that all these tools could be integrated for improving our routine practice in a very simple way, because it's just a question of pushing the right button. And it takes only a few minutes for each of these techniques. Thank you very much for your attention.
We have time for one question. Is there one question from the floor for Professor Correas? Yeah.
We have a strong experience with Explorer, and the papers say there's about 80-something% of sensitivity. But in our material, we detected all significant cancers, only insignificant six Gleason score were not detected. So it is also an advantage of this technique that it doesn't detect non-significant cancers.
Yes, you're right. And this is a very good point. The question is about detection of the Gleason 6 with B mode and shear wave elastography. So basically, we know that the higher Gleason score, the higher stiffness you will see. And this is very interesting because what we want is really to target and to find the aggressive cancers. And the Gleason 6 cancers, at least the smaller ones, are considered to be not benign, but could be just beneficiate from follow-up. So right now, we are not in the picture to say that, you know, if this is small and with a moderate increase of stiffness, then we can just neglect. But at least we can follow the patient, and that's a very key message, is that we can use shear wave elastography and ultrasound for follow-up of the patients.